All right, welcome back everyone, and thank you so much for joining us. And thank you, Dr. Anushka Aubeelack, for joining us for this session.
You're welcome. Looking forward to it.
Yeah, we've really been looking forward to this. It's been a couple of weeks since we started doing these, and just for various reasons, we just haven't quite gotten down to the anesthetics as yet. So thank you so much for enabling us to do that, because I know that for many people out there who are watching this, the anesthetic bit is one of the most scary bits.
Yeah, a lot of people aren't really aware of what we do, so I can imagine that must cause a lot of trepidation.
Yeah, I think it does, but I'm really confident that this video will help to reassure people and help to give people an idea of what it is you do and what to expect when getting ready for for a knee replacement and a hip replacement. But here in particular, we'll be talking about the anesthetic components around that.
Yeah,
so
sounds good.
Before we dig into the nitty-gritty of what happens on the day and the alternatives and all these questions that people have sent in to us, and as ever, thank you so much to everyone who's sent in a question. What do you do? Where do you do it? And sort of what is an anaesthetist? I think that's actually one of the most common questions we've had.
Okay, so as you said, my name is Anushka. I'm one of the anaesthetists, one of the many anaesthetists that we have here in the UK. We're one of the largest departments of any hospital because we basically cover all people, right from being tiny babies right through to the end of their days. So an anaesthetist is a really broad term for someone that looks after people around the time of their operation, but that's not just all that we do. As well as working in the operating theatres, we work in and around the hospital at various locations. So there will always be an anaesthetist who is a member of the emergency response team, or sometimes also known as the cardiac arrest team. So if a patient becomes critically unwell or does have a cardiac arrest in the hospital, an anaesthetist will always attend that. There are anaesthetists who staff the intensive care units. So you may have heard a lot about that in recent times with the coronavirus. Majority of the staff, in terms of the medics, were anaesthetists and intensive care doctors. We also do other kinds of anaesthetic medicine as well. So if you are a patient who has chronic pain issues, you will often attend a pain clinic, which is led by an anaesthetist. It's not just anaesthetists that do chronic pain as well. There are members from the orthopedic surgery area, members from the plastics area, but anaesthetists do run a large majority of those pain clinics. We will also do what's called perioperative clinics. So I guess that ties into our key function, which is to look after patients during their operation and around the time. Perioperative clinics is basically where your surgeon will refer you to us to find out if you are suitable and healthy enough to undergo an operation and an anaesthetic. The other area that you may see us is in transfers. So patients who are unwell, we will transfer those patients in between hospitals. Usually you have to transfer a patient to another hospital because the hospital that they're originally at does not provide the specialist service that they require. So usually something going from what is called a secondary care hospital, which is your normal district general hospital, to one of the specialist hospitals for services such as neurosurgery or cardiothoracic surgery or paediatric care, which needs to be more specialized. Those are the more common examples. But yeah, more common place that you will find us, the more common place that you will encounter us is in and around the time of your operation.
Wow. Okay. So yeah. So anaesthetists cover quite a lot of different things. You're a type of specialist doctor. In the US, some people watching this may know your specialty as anesthesiologists, or occasionally anesthetic doctors or anesthetic specialists. That's also
I feel like there's too many vowels in the American version.
There's a lot of vowels in there for sure. And just in short, for someone who is having a knee replacement or a hip replacement, they're anesthetic doctor, they're anaesthetist, they're anesthesiologist. What kind of training have they done? How many years of training would you do before you're before you've completed training, and how does that work?
So in the UK, so it's very different in the US, and I'm not hugely familiar with their training system, but in the UK, you qualify for medical school. You then do your first 2 years in what's called foundation training. So that is where you have usually 6 rotations of about 4 months each, going through different specialties like GP, A&E, the various different kinds of surgery that we perform, the various different kinds of medicine. And then after the 2 years, which are your foundation years, you then move on to what is called core training. Core training is now 3 years. Core training is also the first period of training in your specialty. So whereas in your foundation years, you're still very much building up a general base of practical knowledge of your career, core training is when you start building up the basic knowledge of your specialty career. Now, remember, these people are all qualified, though. These are all qualified doctors. It's just they are honing their skills. It's like a fancy apprenticeship. So after core training, you then move on to specialty training. And that normally takes between 5 to 7 years. And in that time, as well as becoming more senior in your specialty, you also may develop your subspecialist interests. So, for example, the things that I mentioned previously, intensive care, pain medicine, pre-hospital medicine. So you may also meet an anaesthetist outside of the hospital, where we come to you if you've had a big accident, or we come to you when you're very unwell, and we help the ambulance crew. But after those 5 to 7 years, at that time, you then get what is called your completion certificate of training, with certification of completion of training. Whatever way around it is, CCT. Once you have that, you are then able to have a consultant position. Now, for patients who are coming in for a planned surgery, so for example, your hips, your knees, your gallbladders, whatever, you will come into a list which is always staffed by a consultant, okay? But they may also have, if there is a teaching hospital, a trainee, so a core trainee or a specialist trainee accompanying them who is honing their skills. So you will always have care which is from a consultant, which may include supervised care by a trainee. Okay.
Thanks again. I think that's a really helpful overview, and I guess also in the UK sometimes the people can get a little bit confused around the term junior doctor, which casts a really wide net and may well refer to someone who is, a decade or more on in their training since medical school.
And that's the thing, a junior doctor refers right up to the day before you get your completion certificate of training. So it's a misnomer, that one, isn't it?
Probably. But anyway, I think we've covered the sort of the who and the sort of the higher level of what you do as an anaesthetist. To then move on to the next sort of higher level question: what is anesthesia, or what is a general anesthetic?
So a general anaesthetic is inducing a state of amnesia, analgesia and anesthesia. So you are asleep and you won't remember and you won't feel your operation. That's the aim of a general anaesthetic. A general anaesthetic is a general anaesthetic. It's just the way that we deliver it, whether it's via medicine that goes into a cannula in your hand and circulates around your body that way, or via the airway that we pop into your mouth, which is circulating via your lungs and then via your blood. So 2 ways that we give a general anaesthetic, either in a cannula or via the gases that we use with our machines.
Okay, great. And I guess probably more increasingly so in the past couple of years, there's been a use of doing surgery without being fully asleep, without having the full general anesthetic. And I think that's something that people having knee replacements and hip replacements may well come across as one of the options in the plan for their operation.
Absolutely, and it's actually an excellent option for your surgery. Number one, there are the other different kinds of anesthesia that we can do. So there's something called local anesthesia. So whether that is just injections around an area of skin to make that area of skin numb, or a different kind of local anesthesia, which is called regional anesthesia, where we inject around a nerve. So sometimes we do it up here if we're trying to numb the wrist and the hand, or here where we're trying to numb all of the shoulder as well. Regional anaesthesia, very effective with that. Depending on the operation, we can keep a patient awake for that. There is also the different kind of regional anaesthesia, which is more central. And what I mean by more central is that it involves the spinal cord. So there are two different types. There is the spinal anaesthetic, which is a very small dose of medicine, like no more than 3 mils of medicine, which comprises local anaesthetic and usually a morphine-like drug to, number one, reduce the amount of local anaesthetic we use, but also provide you pain relief that lasts for hours after your operation. Or an epidural, which people may be more familiar with the term of because of women having epidurals in labour when they're in pain with their labour contractions. Both procedures, spinal and epidurals, are used for joint replacements and are incredibly safe and very effective forms of anaesthesia. Number one, because it reduces the amount of drugs that you have to receive and therefore reduces the amount of complications from the drugs that you receive. It means that we don't have to interfere with your breathing. So you are breathing for yourself, you are awake. It can reduce your risk of developing a blood clot afterwards, which is increased with the type of surgery such as big hips, big knee operations. That is an increased risk. So a spinal or an epidural can mitigate that slightly. And then the other thing is that if you don't want to be completely with it, we can give you some sedation just to take the edges off as well. So you can have a snooze whilst you're having a hip done, but without having to have all the drugs involved with a general anaesthetic. So I love regional anaesthesia. I'm in my area of practice, I do general anaesthetics. So what that means is operations for gallbladders and bowels and bones and all sorts. But the other area, my subspecialty, is obstetric anaesthesia. So I am doing 10 to 20 of these regional anaesthesias or analgesias, so pain relief or anaesthesia for an operation, spinals or epidurals, for women who are giving birth. And it's amazing. It's reduced the risks that they encounter with anaesthesia significantly. So yeah, I'm a massive fan.
Great. And so you can have a regional for joint replacement surgery. You can have a regional anaesthetic, and you don't have to be fully awake.
Nope,
so it sounds like you're
have
getting
a little bit of
the best.
sedation.
Yeah, you're getting a little bit of the best of both worlds. But so
It's
for someone,
a great option.
yeah, and so for someone who's then considering having a regional and staying awake, I guess it's worth flagging that you don't need to see what's going on.
Yeah, absolutely. So we, when you are, whether you're having a general anaesthetic or a regional anaesthetic, whether you're completely asleep or whether you're fully awake or whether you have some sedation, at no point do you have to witness your surgery.
Yeah.
Because what we do is when we are what's called draping, so preparing the area within which you're going to be operating, and keeping it all sterile. That involves big sheets that keep all people away and potential dirty people away from the area of the operation. So these sheets create a tent over your head so you don't have to and you won't see anything that you might be fearful that you might see. Yeah. That said, there are still noises. I think the best description of an orthopaedic theatre, so if you are having a hip or a knee, an orthopaedic theatre sounds a little bit like a wood workshop. Lots of drilling, lots of talking to each other, sometimes some music. And so if you can get your head around the idea of it sounding like a wood workshop, actually it takes some of that anxiety away. But that said, you can have some sedation to take the edge off if that's something you were worried about.
Yeah. And indeed, I think many places will offer patients the option of listening to some music of their own choice rather than having to listen to perhaps the surgeons or the anaesthetists' choice of music. Or
I thoroughly advocate bringing in some music or bringing in your iPad, and we can set it up so that you can watch, like, I don't know, David Attenborough or something.
Yeah. And okay, great. Well, this is sounding rather nice in some ways, watching some David Attenborough. But in terms of for those who are awake, and so we've talked about what you might hear and how you can be distracted from that, and you've mentioned that you won't feel any pain, but will you feel anything? What kind of?
So if you are having a regional anaesthesia, you will be awake. So you will feel your body being moved around, but you won't feel anything sharp. So you won't feel pain. So the local anaesthetic works on the nerves which carry pain up to the brain. So it works really well for those. You shouldn't feel any pain at all, but you may feel your leg, your hip, your body being shifted around a little bit. That's completely normal because you're awake. You're going to be aware of that. If you have a general anaesthetic, you won't be aware of anything.
Yeah. Okay. And so there's, we've touched on quite a few different options, and how is the decision around what the best option is for someone? How is that decision made, and what factors are sort of taken into consideration?
So usually in the pre-assessment clinic, what we do is we ask you lots of questions about your health. It may be an anaesthetist, it may be one of our anaesthetic nurses. We ask you all the questions about your health that you've probably been asked umpteen times before. But main things we want to know is, do you have a health condition? Is it stable in that it's on treatment and you've responded to that and you're able to live a normal life? Or is it not completely managed in that you're on treatment but it doesn't quite manage all your symptoms and your daily activities, your lifestyle is slightly compromised? Or are you very much suffering from your health condition? All of these things will contribute to the decision that we make with regards to, number one, can we go ahead with the surgery, and number two, best kind of anaesthetic for you to minimise the impact of that surgery and anaesthetic to your health. So the key here, I know sometimes it's tempting to underestimate, how many glasses of wine you have a week, or if you're still smoking, or if you're maybe taking some recreational drugs that some people might frown upon. It's really important that you don't hide that information from your anaesthetist, because it's critical that we make the safest and right choice for you. So be as honest as you can about your health, what kind of lifestyle you're living. So are you limited by your health? And are you perhaps taking things in that might compromise your health in other ways? So alcohol, smoking, drugs, etc.
Yeah, okay. And in terms of, I guess, carrying on in a fairly general sense, once a decision and a plan has been made for a type of anaesthetic to be used for surgery, how quickly does it take to have its effect?
So a general anaesthetic, I know the common thing on entertainment is that, we get the patient to count down from 10 and they barely make it past 8. And that's true. So with an anaesthetic, as soon as we start the actual general anaesthetic, you're asleep within seconds. With regards to spinals, epidurals, from the time they go in, we anticipate that they should give you surgical anaesthesia, so they should be surgery happy, basically, for at least a couple of hours. And we expect their effects to wear off between 8 to 12 hours. So if it hasn't worn off within 6 or 7, don't worry, it's okay. Your legs and your power, your sensation will come back to normal. It just maybe for you it takes a little bit longer. But don't wish it away, because when the anaesthesia, the regional anaesthesia wears off, you need to start taking pain relief.
Yeah, and you need it to wear off to be able to get up and going and moving.
Exactly.
As with so many other things that we discuss in these videos, it's about finding a balance.
Yeah.
And for those, there have been a few people who are a bit concerned about the idea of having a regional, being awake, and then sort of wearing off during the operation, or starting to feel a bit of discomfort or pain. Is that something that you are able to keep an eye on? Would you as a patient need to sort of say something to the anaesthetist, and can that then be addressed?
Yeah, absolutely. So no matter what, our plan B will always be a general anaesthetic. So if for any reason you feel any sensation at all, just let us know. And if it's towards the end of the operation, we can give you a nice strong painkiller to get you through the end of it. But if it's worn off faster than we've expected, we'll send you off to sleep.
Okay. And then, so we've talked about some of the different types.
It's uncommon.
Oh yeah, that's also worth saying. Very, very uncommon.
It is uncommon for a spinal to wear off before we expect it to, just to make that super clear.
Yeah, that's a very important point. And so we've talked then about going into the anaesthetic. What about in terms of coming out of the anaesthetic? How how long does it take to wear off, generally speaking?
So spinal anaesthetic, usually within 8 hours, people have their power and sensation back. And their legs. For the general anaesthetic, we wake you up as soon as the operation is over, but you sort of become aware that you're awake about an hour or so afterwards. And we advise that you have someone with you for the first 24 hours after an operation with a general anaesthetic, and that you don't go driving up until 48 hours after, because there may still be some residual effects even though you're feeling completely normal.
Yeah, absolutely. And as you mentioned earlier, that's also why you will be given a specific pain management plan from your team, and to take that as prescribed to help sort of bridge that transition from the anesthetic pain relief wearing off, and now helping to maintain good control of any discomfort after the operation.
Yes, exactly.
And then any other points around recovery? Are there, in terms of sort of the possible side effects that you might experience afterwards, what sort of things would you typically be discussing with someone who's getting ready for a joint replacement?
So for a general anaesthetic, the common things that we consent for are a reaction to one of the drugs that we give you. So if you've had a general anaesthetic before, then we generally expect you not to develop a new complication from the general anaesthetic drugs that we use, but it's something that we warn you about. If you've not had a general anaesthetic before, then we don't know how you will respond. So we have to let you know you may react to one of the drugs that we give you. Same with regards to antibiotics that we give you prior to the operation starting, or any of the other medications, and many medications that are involved in a general anaesthetic. So drug reaction is number one. Number two, some people are more sensitive to our anaesthetic drugs than others. So we specifically talk about this reaction, which is post-operative nausea and vomiting. So some people, as the vapors that we use in our anaesthetic drugs, the gases, until they are fully out of their system, they feel quite unwell with it. Now, we have medications to help minimize the nausea and vomiting symptoms, but sometimes still we cannot get on top of it, and something that you need to be aware of. It's uncommon, but it's something that can happen. It's incredibly common to get a sore throat afterwards, because we are popping an airway into your mouth, into your throat, to support your breathing. Okay. So very common to develop a sore throat or a hoarse voice afterwards. The main thing is that it will recover within a week or two. If you find that it's not getting any better, you need to go to your GP to get in contact with the anaesthetic department. And the other common complication that we consent for is damage to your teeth. So because we sometimes use metal instruments in the mouth, and certainly for long operations that will be the case, that we use a metal instrument to help assist us get your airway in, metal and teeth are not happy partners, and it can cause damage. Again, it's an uncommon risk, and in an elective operation, a planned operation, you will be having a consultant there, so you'll have someone who is very experienced with airways. However, it's still something that can occur, especially if you have bridges or caps. Those are slightly higher risk dental work to have this complication. A lot of people are worried about awareness. A lot of people are worried about, dare I say it, death with a general anaesthetic. It's uncommon. For planned operations, we will not give you a general anaesthetic if we think you're going to suffer that risk, because it's planned. So there are alternatives that we can do to get you through your operation safely. It's unusual for us to not be able to do any form of anaesthetic whatsoever, but it's a conversation that will be had in depth with you if you are someone of poor health generally.
Okay, and so that's an overview of this potential side effects and some of the complications that you touched on for a general anaesthetic. How would that conversation be different for a regional? Let's say someone who's having a regional, and then with or without sedation for a knee.
So with sedation, the same rules apply regarding having someone with you for 24 hours afterwards, and not operating any heavy machinery for up to 48 hours, or driving for up to 48 hours afterwards. So that's sedation. Otherwise, sedation actually is pretty simple. In terms of the regional anaesthetic, so when I talk about that, specifically spinals or epidurals that are given to you in a dose that is suitable for surgery, there are several common side effects and risks that we will discuss with you. So let's do the side effects first. When the medicine takes hold, it can drop your blood pressure, which can make you feel quite dizzy, nauseous, hot and sweaty, like you're about to faint. Now, we have medications to bring your blood pressure back up again, but we need to know if you're getting those symptoms early on, because that means we can get on top of it quicker, and that can stop you fainting or feeling sick and being sick. So if you tell us sooner if you're getting any of those sort of dizzy, hot flush sensations, we can give you the medication to bring your blood pressure up nice and quickly. Though we are monitoring your blood pressure regularly, the patient is often our best indicator of what's going well and what's going not so well. Sometimes the opioid part, what I mean, like the morphine-like part of the medication, can make you feel quite itchy. So that we can give you medications to try and reduce the itch, but it's that balance again. What it does, it gives you great pain relief for hours after your operation, so you want it in there, but a possible complication is that you get quite itchy afterwards, and so swings and roundabouts, what's worse? I think pain, so we'll try and treat the itch as best as we can, and it does wear off as soon as the morphine comes out of your system. Now, with regards to your legs, because we numb them up, they're not working, they're weak, they're not safe for you to stand on, we advise that you have a urinary catheter placed, so that you don't have to worry about passing urine, you don't get retained urine in your bladder, which can sometimes be very uncomfortable. So whilst you have a spinal, when it's working, one of the nurses will place a catheter so you don't feel that go in, but you may feel slightly uncomfortable. It's not painful, it's just weird when it comes out. And it comes out when your legs are fully functional and you are safely able to transfer yourself from bed to the toilet. So those are the common side effects. So I've mentioned itching, I've mentioned blood pressure dropping, making you feel a bit woozy, sick sometimes. I've mentioned the fact you will need a catheter. Shivering and shaking, because the way that spinals work, it numbs your nerves, so it numbs how well the lower half of your body is able to maintain your temperature control. You can end up getting a core temperature that's a bit colder than you would normally have it if you were maintaining it yourself. So during the operation, we do give you heating blankets during, so you stay nice and toasty. But sometimes if you ask us to switch it off because you're getting a bit warm, you can then end up shivering and shaking because your body's got colder than you sense you are. So that's another thing to be aware of. You might get like shivers.
Okay.
In terms of risks, so there is, with regards to a spinal, there is a 1 in 500 chance of developing a specific kind of headache called a post-dural puncture headache. It's less than with an epidural, which is 1 in 100, because a spinal needle is much, much smaller. It's very thin, so the risk is therefore less than an epidural, which is a little bit wider. A post-dural puncture headache is not necessarily life-threatening or health-threatening, but it can be very uncomfortable and it can be very inconvenient. So lots of people get headaches in and around the time of their operations. They're stressed, they're anxious, but it's a normal headache for them, a tension headache. If the nurses believe that this headache is unusual and more likely to be an anaesthetic-related headache, they will ask us to come review you, and then we will discuss how we manage it. Usually, most go away completely on their own with just conservative measures. So what I mean by that is keeping hydrated, taking normal pain relief, resting lots, but some require a second procedure. And if you are one of those people that develop that complication, we can talk about what that procedure is. It's no more complicated than another injection in your back. Other complications people are concerned about: nerve damage. So we have the numbers for epidurals. So remember that epidurals are slightly more risky because of bigger needle, but that said, the risks are rare. So for a temporary nerve damage, so what I mean by that is maybe a patch of skin on the leg, being a bit numb, right through to loss of use of one leg, can last up to 6 months. So it's temporary. That is 1 in 1,000 chance. Okay, and which is rare. The likelihood of that kind of damage being permanent for an epidural is 1 in 13,000. So getting into very rare. The chance of you becoming paralysed, because there are lots of urban legends and urban myths out there about everyone getting paralysed who has an epidural, it is not true. There is a number attributed, which is 1 in 250,000. However, in experienced hands, that risk is much, much less. The other things you need to be aware of is any time you break the skin, you are at risk of causing pain, you are at risk of causing bleeding, you are at risk of causing infection. So with regards to those two things, bleeding and infection, bleeding, a clot, which is called in medical terms a hematoma, but a hematoma in the area of your epidural space, so has potential impact on the nerves innervating your legs, is around 1 in 50,000, and the same applies to an infection in that area, which may be in the form of an abscess, so a collection of infection, or an infection that can spread up to your brain called meningitis. So that's 1 in 50,000. So we're moving into extremely rare territory. Things you need to be aware of, things that are incredibly unlikely to occur, but as we enter a more litigious time in medicine, it's things that we unfortunately have to get you to sign that you accept the risk of.
No. So I mean, it's I guess it's very similar to when discussing the possible risks and complications of the operation itself. You know, it can be very daunting, but it's an important part of making an informed decision, being informed as a patient, being getting an idea of what to expect, and then using that hopefully to be a bit more empowered about some of the things that you can do individually to help reduce your personal risks.
Exactly.
But yeah, so we've touched on quite a few rare things there. If we go back to something that I think almost everyone will be asked to do, and that's having an empty stomach before the operation. Why is that important?
So, as I mentioned earlier, our plan B is always a general anaesthetic. Now, for a general anaesthetic, you need an empty stomach because it reduces the likelihood of stomach contents when you are asleep making their way passively up into your mouth and going into your lungs. Now, stomach contents, as well as can be dirty because they have food in, they can be very abrasive chemically because your stomach acid is very acidic, and so the tissues in your lungs can become potentially permanently damaged by that chemical damage from the stomach acid. So that's why we say before your operation, no solids for 6 hours. Milk, when it goes into your stomach, turns into a solid. So no milk in your tea, no milk on your whatever, no milk included in the solids. In terms of fluids, we say you can have clear fluids. So what I mean by that is when you hold a glass up to a newspaper, you can read through it. That fluid is not fizzy. It has no bits in, okay? You can have that up to 2 hours before the operation. And we think, and we have evidence, and there are studies that have been conducted which show that by the time that those 6 hours have passed for solids and 2 hours have passed for clear liquids, most stomach contents have passed on further along your gastrointestinal tract. So your stomach is fairly empty, and therefore the risk of you aspirating, that's what we use as a term to describe food or acid going into your lungs, the risk of your aspirating any contents which are damaging to your lungs is greatly reduced. So it's really important. It's so important. Chewing gum also, because it stimulates acid production in your stomach, is counted as a solid. So no chewing gum either, which I know when you've not had a drink for 2 hours, you feel a bit self-conscious about your breath. Honest to God, the next patient's is probably far worse than yours. So don't worry. Okay, we've seen and heard and experienced it all. We don't care. We want you to be safe.
Yeah. And I know, just because a few people have asked about indigestion tablets, it's the same thing. You may well get a little bit of indigestion from not eating and from waiting, but indigestion tablets, as I understand, most people will advise against them as well.
So things like the Gaviscon tablets, which you have to suck, and that are they've just got like a bit of antacid in them. Those ones, no, we don't want you having those. But your regular medications, we do want you to have, unless we advise specific ones to avoid. So there's certain blood pressure medications, blood thinning medications that we tell you not to take, and we advise you when to stop those. Most of your regular medications you can have with a small amount of water, and we generally prefer it because it means that you are in your most normal controlled health state that we can get you going into your general or your regional anaesthetic.
Yeah. And again, I mean, that's as with all the videos in here in these Joint School live sessions, and as with every part of your care plan of the organization and the steps that your team will take around an operation, it's individualized and it's customized to you. And of course, this conversation doesn't replace anything. It always comes down to what your healthcare plan, what your team have put in place for you. But hopefully some of these points here will help to be another point of reference to
demystify some of the stuff. What your neighbours told you about their Aunt Berry who had a hip, and then honest to God.
Absolutely. So thank you so much, Anushka, for taking the time to run through this. I think you've really done a great job of covering some of these frequently asked questions around having an anaesthetic for a joint replacement.
You're very welcome.
No, thank you so much. To sign off, is there anything that, what would be your top tips for someone who's watching this now, who is awaiting or getting ready for a joint replacement in terms of the anaesthetic side of things?
It has the anaesthetic side of things. So if you have any health concerns at all that you are, you haven't mentioned to your GP, but you are a little bit mildly concerned about, go and get those sorted. Get everything sorted before your operation as much as you can, because if we find on the day that things aren't the way that we want them to be, we will cancel your operation because it's not safe to go ahead. If there's a way, I know that you will have a painful knee or painful hip, and that's often it's so painful you can't do daily activities. If there is a way to improve your exercise tolerance, so you can do sitting exercises, that's also very useful just to improve your cardiovascular health. And even the smallest way, incredibly helpful. If you are a smoker, please consider stopping before your general anaesthetic. I know it seems like we're asking a bit much, but there is a reason, and it can increase your risk of a chest infection after the operation. We don't want that for you. So if you can at least just put a pause on for at least a week, it makes a significant difference to how well you fare during a general anaesthetic. And if you feel like you're getting a bit viral, a little bit coldy, call in to the anaesthetic clinic to get an opinion from an anaesthetist before the day of your operation, because sometimes, again, if you've got a cold, we're not hugely happy to go ahead with the anaesthetic because it's a planned anaesthetic. Why take a risk that you don't need to? So the earlier that we know about that, the better, because it means that we can also put in place some things to maybe help you get back on form a little bit quicker.
And of course, that's especially true now with COVID-19 around.
Yes. And there are strict protocols in place with regards to if you think you've got any symptoms with regards to coronavirus. So I am working on the elective side currently, and we very much are hot on swabs and symptoms and all the rest of it. So if there's any chance that you may have it, because of the increased risk that coronavirus poses to recovery after an operation, we will not go ahead. But it's about your safety. It's not because we're wanting to drink a cup of tea, I promise. It's because we want to make sure you go through your operation, you recover well, and you get the benefit that the operation is originally intended for.
Absolutely. Well, I think that's a positive note to end this session on. Thank you so much, Anushka, for joining us. And thank you everyone for watching. As ever, let us know what you think in the comments below, or by sending in an email. Send in any questions or suggestions for other topics, or indeed if this conversation has sparked something that you'd still like to know more about, let us know and we'll dig into it. All right, everyone, thank you so much and all the best until next time. Take care.